Yes, please.
We are live, Dr. Elena.
Hello. Can you share your slide? Are we ready? Are you ready to start? Can I start?
Yes.
Dear colleagues from all over the world, I'm Elena Goranova from Bulgaria, and I am the president of Balkan Venous Forum. On behalf of our society, please feel very welcome to this webinar of lymphology. Next one. You are welcome. Benvenido, benvenuti. The next. Next. There are 271 live events included in this initiative from all continents. Next. There are 114 developers from all continents in the 1 week. Next. There is a special program for each day. Next. We are in the 1 week. Next. SOFIA project focuses on the scientific objectives for international angiology and is a common initiative between Win Foundation and BVF. BVF was born in Belgrade more than 11 years ago. It unites vascular surgeons, dermatologists, phlebologists from the Balkan countries to share our expertise, experience in a perspective to upgrade our patients' quality of life. One of the lectures will be provided by Professor Tanja Rusidzaj from Slovenia, and you will be approached by Professor Daniela Radu from Romania. Both are founders and current BVF vice presidents. You will also meet Sokol Jepa, Spiros Vazdekis, Dimitar Dimitrov, and Vasily Petrov, who are also members of our society. The next one, please. Next. You can enjoy simultaneous translation on two more languages, Spanish and Bulgarian. You have just to click on the right button. Next. You have, you can ask your question on the Q&A or write them. Yeah, yes. Here is the place to say thank you for our sponsors.
SOFIA project became possible with the support of our sponsors. Laboratoire Servier. For more than 27 years in Bulgaria, Servier is dedicated to the public awareness, detection, and early treatment of the chronic venous diseases. Health 2000 Limited, the local distributor of USO products, the perfect support to make movement more enjoyable. Valentis, the Swiss quality, from natural ingredients to nanotechnologies. Valentis seeks to take the lead in all areas of natural medical treatment. Teva, a global leader in the pharmaceutical industries, developing, producing, and marketing affordable, high-quality generic. Inothera, Inotech Bulgaria, treat daily pathologies.
Next. I wish you to spend a very interesting 90 minutes with this program that are on the way. And now I give the floor to our ex-president, Professor Athanasios Giannoukas from Greece, to greet all of you. Athanasios.
Thank you very much, Elena. Thank you very much, Elena.
it is my pleasure to welcome all our distinguished speakers participating in this SOFIA project. And I would like to say how much excited I am and thankful to the organizers of the whole event that they have selected me to co-chair this session with you. I'm sure that this is going to be a very interesting session. The speakers are well-known scientists working especially in the field of lymphology. And I'm sure that for all attendees of this webinar, this will be a very good opportunity to have a summary of what is the advances in lymphology. Therefore, I give you the microphone to introduce the first speaker.
Unmute yourself, Elena.
Next slide, please, Khaled. This is the Vice President of the Bulgarian Medical Association, Nikola Gabrovsky, who will say a welcome to all of us. Next.
Уважаеми господин Ночев, уважаеми, благодаря за поканата. Радвам се, че макар и точно в Световната седмица за венозно и лимфно здраве мога да бъда сред вас. Истината е, че в България до голяма степен сме длъжници на хората, страдащи от лимфедема. За съжаление, у нас все още няма статистика какъв е техния брой. Общия риск от лимфедем при всички видове рак се смята, че е малко над 15%, като той не намалява времето, а продължава да съществува през целия живот. Според предварителни данни на Националния раков регистър към януари 2021 година сочат, че поне 250 000 души от нас страдат от онкологично заболяване, което означава, че близо 39 000 души в България страдат или са в рискова група за лимфедема. Затова е особено важно да говорим и да се съсредоточим усилията си в профилактиката, ранната диагноза, водеща до по-ефективно лечение. Днес с недостатъците обаче трябва да посочим и добрите примери от България. Един от тях е в програмата Виктория – комплексна рехабилитация на пациенти след хирургия и активно лечение на рак на гърдата. Програмата предоставя профилактика, лечение на лимфния застой и свързаните с него последици при нарушена двигателна активност, тежест и болка в ръката. Извършва се индивидуална и групова кинезитерапия, лимфодренаж, апаратен и ръчен. Програмата е финансирана от бюджета на Министерството на здравеопазването и един от добрите примери за систематизиран комплексен метод в България. Създадена за поетапна рехабилитация на медицински, социални и психологически проблеми на пациенти, оперирани от онкологично заболяване, преминаващи или преминали курс на лечение с химиотерапия или лъчетерапия. Фактът, че форумът се подрадва на такава представителност от международни специалисти ме кара да бъда оптимист. Оптимист, че това е правилният път и че решаването на проблемите може да бъде намерено. Уважаеми колеги, пожелавам ви ползотворна работа, а на организаторите на събитието успех!
Next presentation, please. Khaled. Khaled, can you hear me? I would like to introduce Professor Sergio Genesini from Ferrara, Italy. I have deeply thanks for Professor Sergio for his great contribution and activity for doing this webinar possible. And he also invited a guest of honor on this event and concluding remarks provider. But let's hear to Professor Sergio.
Thank you so much, Elena, and thank you so much to all the Balkan Venous Forum organization. Indeed, it has been just a huge pleasure to co-work together and to point out the importance of venous and lymphatic disease. We touched this point multiple times during these Vein Week days. Very probably we have to deal with the most democratic disease with venous and lymphatic, meaning that a vast part of the population is affected by that. It is important to bring awareness in all the medical specialties as well as in the population. For this reason, I'm honored to start with the introduction from Francesco Noce, who is a wonderful health professional in representation of the Italian Board of Physicians and on the importance of international and multi-specialty teamwork.
Dear colleagues, I'd like to congratulate the Bulgarian organizer of this important initiative addressed to lymphedema, the hidden epidemic. As a representative of the Physician Board of Veneto region, I am particularly glad appreciating the scientific and educational content of this multi-speciality webinar focusing on the hydrotherapy topic. Italy and Bulgaria are blessed by hot springs, potentially benefiting venous lymphatic patients. So I applaud this meeting of experts who will be able to provide more notion in what is well demonstrated and still to be investigated for the proper treatment of the many patients affected. Hoping to have soon the chance to meet each other in person in the beautiful Italian Bulgaria. I wish you all nice and safe day.
And with this, we deeply thank Dr. Noce that indeed touched the similarities we have from the two broadcasting places of today, Italy and Bulgaria, also in terms of hot springs. And for this reason, I've been asked to talk about a recent publication we placed on preview zones, so data we were collecting on the aquatic environment for our venous and lymphatic patients. These are my conflicts of interest. And indeed, I think it is very interesting to notice how much it is spent in the aquatic environment in terms of spa activities. This is the report of the Global Spa and Wellness Summit per year. But it is also interesting to notice how in the literature we see that we have to work a little bit more to produce evidence-based data on our venous and lymphatic field. You can notice from this publication, for example, that our colleagues from the rheumatological world produced a significant amount of literature on the benefits from the aquatic environment, while we are at the bottom of the tail over here as venous and lymphatic experts. There are indeed some interesting publications from the past, mainly focusing on the quality of life, though. So that every single day our patients are enjoying the aquatic environment, but not really understanding what's going on in terms of venous and lymphatic circulation. If we go back to the 90s, we see interesting papers, for example, from the group of Ernst, who already demonstrated that the lower limb volume control and also the hemodynamic improvement in subjects undergoing aquatic activities. But as always in science, we need standardization and reproducibility of the data. And here you can see the protocol that was used that clearly is quite difficult to be reproduced in all our patients. If we go to the 2009 time, we see another interesting paper from Carpentier, even with a crossover modality, showing the benefit inside and outside the aquatic environment, meaning doing the same activities inside and outside, but in terms of pain for our patients. The problem is that also in this publication, we can read that the type of balneotherapy was chosen by the spa physician for each and every patient. So there was a significant heterogeneity in the protocol that was applied. The potential benefit is significant from a physical standpoint. If we remember, for example, the Staving law, that is pointing out that every single centimeter of water is equivalent to around 0.7 millimeter mercury, which means that we have a graduated pressure that is ranging up to 80 millimeter of mercury and more when we are more or less at 120 centimeter of depth. For this reason, back in 2017, we published a first documentation of a standardized reproducible protocol we developed in a non-thermal aquatic environment, so a normal pool, involving patients affected by flammable lymphedema with detailed inclusion and exclusion criteria, looking at the lower limb volume variation after 2 sessions per week, 50 minutes each of this standardized protocol. As you can see, there was a significant improvement in the lower limb volume that was pretty significant, around 300 mils after the 5 sessions, with an improvement in the subcutaneous thickness. And you see Michael Jackson over here, because in the protocol we included also the backward walking, so like the moonwalk of Michael Jackson, because Dixie already demonstrated that walking backward, there is an increased movement of the ankle joint. And indeed, this ankle joint range of motion improved significantly after the 5 sessions. Also, the lower limb heaviness feeling improved, while the functional ambulation classification did not improve. This is a validated scale to assess how the patient is walking. But back in 2017 publication, we were not really able to answer to this question. Is it the protocol we were using of physical exercise giving this benefit, or is it the use of the aquatic environment? For this reason, back in 2017, we started a very serious randomized comparative trial that looked at the same population, performing the same protocol inside, in this case, a thermal aquatic environment versus dry land. This is now published on JVS, and it was looking basically at the same outcome measures we were assessing in the previous investigation. The study was performed in the hot springs of Abano Terme near Venice, where I hope we will be together as soon as possible. The Dryland exercises were performed in our University of Ferrara Center. The protocol was exactly the same. The protocol is available for free in the paper of 2017. And as you can see, is basically moving all the lower limb joints with a standardized group of series and repetitions. What we observed in terms of lower limb volume variation was that after the 5 sessions, there was an improvement in the thermal aquatic group, while there was no significant variation in the dryland group. In terms of subcutaneous thickness assessed at the points you see reported clearly over here, there was an improvement again just in the aquatic group. In terms of great saphenous vein caliber at the assessment point, there was an improvement again just in the aquatic group. And again, Michael Jackson, if we look at the ankle range of motion, we see that in both groups, aquatic and dryland, there was an improvement, but the improvement was greater in the thermal aquatic group. Of course, the statistical correlation between lower limb volume variations and ankle range of motions was just in the thermal aquatic group. Quality of life is really important, but it has to be assessed in a standardized way. So we used the CIVIC that showed an improvement in both groups, while VIVIM-CQ showed an improvement just in the thermal aquatic group. In another publication recently done by our group, we pointed out the bioimpedance data of this activity, pointing out how in the aquatic group we had a significant decrease in the extracellular fluids. That, interestingly, was correlated with the lower limb volume variation, as in the other publication of JVS, the ankle range of motion was correlated with the lower limb volume variation. In conclusion, we can now answer that a standardized, reproducible aquatic protocol of exercises performed inside a thermal aquatic environment can provide a benefit compared to the same exercise outside the pool in terms of lower limb volume variation, thickness, ankle range of motion, extracellular fluids, and quality of life. Of course, there is a lot of investigation to do regarding the different kinds of water involved. But it is a starting point, I think, to move from empiricism toward evidence-based science. And for this, I'd like to deeply thank Erika Menegatti, our PhD mainly involved in these research projects. That, of course, are touching not just physics, but also the chemical properties and also the thermal properties of the aquatic environment, for which we could eventually discuss later on. Again, the road is still long in terms of evidence-based data on this topic. These are the Organis hills near Venice, near the hot springs I was mentioning, where I hope we will be once again together as we have been together in the past. This is the winter 2019 meeting with the related document where you can find some of the considerations I made here. The next big winter will be focused on an equally important topic, I think, which is venous lymphatic fake news, because there is a lot of, for example, promotion of aquatic activities that are not really evidence-based, for which this will be part of the document as well. I deeply thank the Balkan Venous Forum and all the organizations already involved in this global project. You can report eventually encounter the fake news in this web page. It will stimulate the discussion of experts inside the consensus document that will be presented during the Universal Expo in Dubai, February 3-5, 2022. But not before, hopefully, stopping in Bulgaria for some other wonderful initiative like the one of today, for which I deeply thank once again Professor Goranov, Professor Janokes, and all the Balkan Venous Forum.
Thank you very much, Sergio, for this great presentation. I absolutely agree of the benefit and impact of the water procedure on the lymphedema. And we have another discussion for this. May we have the slide with the presenters? I would like to introduce Amore from Argentina. Do you have Amore online?
No, Miguel has a video, so I think Khaled will play a video. Unless Miguel is here, but I don't see him.
Congratulations, Sergio, for this important research and these certificated potential benefits of exercise in water. And my question is if you perform the chemical analysis of the water in order to know the percent of sodium, magnesium, calcium. Thank you very much.
And this is a brilliant question. Indeed, it is fundamental to know what kind of water we are talking about, particularly when we are talking about hot springs. As I was mentioning, there are chemical and also thermal properties to be taken into consideration together with the physics one. In the JVS publication, you can find a detailed table with the chemical analysis performed on the water we used. That is also reporting all, again, the physical properties of conductivity, for example, and also density. That is another aspect we could discuss about. And on this, if I can actually add a thing that is important, it's not just about sodium and so on, but also in particular the sulfide components. And there is an interesting publication that is showing the potential role of hydrogen sulfide on the thrombolytic aspects of the circulation, for which further investigation on this will be particularly interesting, I think, particularly in COVID time, in which we could consider the aquatic environment as a rehab scenario for our post-thrombotic patients.
Thank you. Thank you very much for this answer. We have another question or comment from Professor Mokoto Mo from Yokohama University from Japan. Khaled, please, may we have his comment?
Khaled, please play the video.
This is a discussion for Sergio. I'm very impressed in the presentation about the relationship between exercise and the venous disease. Hydro-free exercise include the following activity: about 30 minutes exercise protocol. It requires 2 days per week, and the pool had a depth of 120 centimeters. Here is my question. Pool depth is 120 centimeters. Is it a essential depth? For severe patient, it is not easy to go to super or swimming pool 2 weeks per day. How about doing exercise in their bathtub? Japanese bathtub, fortunately, are deeper than Western bathtub. Thank you very much.
And I deeply thank Professor Mo Well, I see is also with us, and it's actually make me remembering the wonderful Japan and the wonderful hot springs you have there. So we really understand a lot of our countries are endowed with these potential powerful tool, and it will be interesting, I think, to investigate this more for our patients. Very interesting question. From a physical standpoint, I think that in Japan, you have already a class 2 compression in your bathroom, because if it is a 40, 50 centimeters, it means that you are having around 40 minutes of mercury already at the bottom of those basins. This, of course, is pointing out the role of the pressure dose, that even if we change, for example, the density and we go to the wonderful region of the Dead Sea, you are going to 1.3 as density compared to around 1 of the normal pools. So the change in pressures is really relative. It's also true that if we look at our ankles at the end of a long day, wearing not compression stockings, but just a normal socks, we still have the sign of the elastic, which means that we don't need that much pressure to create an anti-edema effect. It would be really interesting to see the chemical properties of the water we are talking about, and also the thermal one, because there could be a discussion also on hot versus cold, because it's not so true that hot is that bad. It really depends on how hot. But if we think about the cross-sectional area of a vessel, there could be an increase in the flow even in hot water. So thank you so much, Professor Mo. Thank you so much, Makoto.
Thank you.
I think that Professor Daniela Radu is online. She's a professor from the University of Medicine and Pharmacy Victor Bis from Timișoara, Romania. Please, Daniela, you have the microphone, the mic. Daniela, are you online?
If she's not here, I see we have Spiros meanwhile.
The next comment, expert discussion.
I take this opportunity to deeply thank the organizer of the Congress, especially Dr. Elena Goranova, for this hard work. I am honored by the invitation. The study evidence-based hydrotherapy for venous lymphatic patients show a new way to increase quality of life for these patients with leg edema, based on fact that the mineral content of spa water has special health-giving properties. Hydrotherapy also uses water massage via water jet directly on the body. This type of massage increases blood circulation and delivers more oxygen and nutrients to the soft tissues. The lymphatic system also activated, giving a generous boost to the immune system, and message on cellulite-prone areas help to break down the fatty deposits and lessen in its appearance. During a hydrotherapy treatment, another health benefit is to release of endorphins, give a sense of well-being. They also block the pain and stress relief, contributing to the disappearance of symptoms without side effects. The base hemodynamic principles of transcapillary filtration and oncotic pressure leading to edema have been known for decades, and the beneficial effect of exercise in cold water to improve lymphatic drainage and to reduce capillary filtration, quantitation of leg edema as well. I had a real surprise to hear something altogether new regarding the positive and healing effect of the thermal hot water of Abanotherme on the chronic lymph edema. The study in question is both challenging and interesting. However, as it is an issue that has never been approached before, in my opinion, it needs a more extensive and deep research for some valid conclusions. Its efficiency, I am convinced, will be proved in the long run, but when only time will tell. I congratulate Dr. Sergio Gianesini for his this excellent presentation and novelty, and it is the starting point for further investigation and studies. I also congratulate all the participants of in this Congress for their efforts to share their ideas and studies. Thank you.
I deeply thank Professor Radu. She's offering actually so many topics that would deserve another webinar just to answer to this. But I will focus on what she said regarding the massage effect. And we have huge experts here with Bibi Lee, like as a frontline of the giants of this topic, and many others who are here today. I'm not aware of serious randomized comparative trials investigating this massage effect with the consequential improvement in the flow that was quoted. And I think it's very important to stress this out to avoid our patients to spend time and money in activities that are not really evidence-based. So that would be a first comment. I think it is very good what Professor Radu pointed out regarding the need of science. More than the long run, I think we need properly designed studies. We need randomized comparative trials looking at these aspects. And she also touched the point of endorphins that could be, of course, a great benefit of the aquatic environment, but also, on the other side of the coin, a potential bias because, of course, we feel better when we go to the spa. So then we don't know if we are feeling better because there has been an improvement because of our health status or because just of these endorphins, for which I really encourage investigations with validated quality of life scores. You're mute, Elena, if you can unmute yourself. You're mute. Okay. You're still mute. Okay.
Yes. So thank you, Sergio. Thank you for your answer. I would like to introduce Professor Spiros Vazdekis from the National and Kapodistrian University of Athens, Greece, who is also the secretary of our Borkovodius Forum. Spiros, the mic is yours.
Yes, thank you, Elena. Thank you for the invitation to this meeting. Dear Sergio, dear Professor Gianesini, I was impressed by your presentation, the data you showed us. There is so poor research on the effect of hydrotherapy on venous hemodynamics, and I think that your exercise protocol is quite simple and should be included even in the guidelines. I have two questions or comments. The first is whether you have any study with a control group in a normal swimming pool. I mean, thermal spa and normal water. We should find out whether it's the hydrostatic effect of water or the mineral qualities of the thermal spa that influence the results. The second comment is that we know that the thermal spas are popular because they have a long-term beneficial result in skin and musculoskeletal disorders. My question is, do you know if your thermal spa good results lasted for a long time? Thank you again.
These are two brilliant questions, dear Spiros. Regarding the data in not thermal waters, the publication of 2017 was performed in non-thermal water. And we had an improvement, as I showed, not as much as in the hot springs, but this does not mean that we can come to the conclusion that hot springs are better, meaning that we didn't compare homogeneous populations. There were like two separate studies, so it will be interesting in the future, again, with a properly designed randomized comparative trial. Regarding the long-run effect, I can tell you that I was presenting, for example, in 2017 data, the 300 mils improvement after 5 sessions. If I take from one session to the other, so after 4 days, basically, or 3 days, I have the results that is stable for 2 days in terms of edema, and then at the 3rd days, I again develop edema. But of course, nobody wants to propose aquatic activities as a pill that you take once and then you solve your issues. It's part of the lifestyle of our patients, I think. And we have to discriminate what is evidence-based data production, for which we really need to use standardized protocol so that they are reproducible in other centers. So we can start from Japan to Bulgaria to Greece to Italy to analyze different kinds also of waters, to what is an everyday evidence-based derived suggestion for our patients. For example, in Italy, a lot of our patients go walking along the seaside with the water up to their knee. Now, the suggestion after this investigation is go a little bit deeper, go on the way to the navel so you have more pressure. Walk, for example, backward, because in this way you will activate more the ankle range of motion. And if this becomes an habit for the patients who can do that in a pool or by the seaside or in a Japanese bath, I think we will move forward with improvement of our patients' management. Thank you so much.
Thank you. Thank you very much for your answer. And going for the next presentation, I would like to ask Athanasius to present Tanya Rusijai.
Thank you very much, Elena. It is my pleasure to present Tanya Rusijai from Slovenia, who is a very good friend of mine, as well as is a very active member of the Balkan Venous Forum. So Tanya will be listening to you about a very interesting question, lymphedema and erysipelas, egg or chicken. The microphone is yours.
Dear colleague, thank you for invitation. And thank you, Elena, that I am with you and the other friends, not in live, but in live, but by WebEx. So what is the first, lymphedema or erysipelas? If we are talking about erysipelas, we have to know that in many countries they say cellulitis or erysipelas, that it's bacterial infection of the skin and subcutaneous tissue is very often those infection, and erysipelas is infection of the upper dermis, and cellulitis is infection of the lower dermis. But we have to know that cellulitis might extend to the superficial, and erysipelas can go deeply in the skin. And many of papers said that erysipelas is just a form of cellulitis. And when we are reading different literature, we can see that in UK, use only the term cellulitis, but in continental Europe, erysipelas and cellulitis are two different clinical pictures or entities. Staphylococcus aureus, Streptococcus group A, Haemophilus influenzae type B, a lot of time cause cellulitis, and erysipelas is after Streptococcus infection group A, C, and G. We can see blistering on cellulitis or erysipelas. Cellulitis is usually diffuse tissue damage, and erysipelas, it's a lot of time sharply limited tissue damage. We can see that a lot of patients we have in our countries in last 5 or 10 years, in United States, increased in 8 years for 4.5 million ambulatory visits for cellulitis or abscess during this infection, and those incidence rates is increasing, most of all because of the acquired MRSA, and hospitalization of cellulitis is going up too in United States, and I think in the other countries too. Lymphedema has been shown in several studies to be stronger risk factor for cellulitis or erysipelas, especially in recurrent cellulitis or erysipelas. This is patient who have a lot of cellulitis and she didn't treat in that time because she wants to do that, and we can see that after 10 years worsening. We can see here what clinical picture, lymphedema and acute cellulitis of that patient, and the patient, man, who have first erysipelas and then lymphedema start. So what is entry point for those bacteria which are usually at our skin? Entry points are fungal issue, lymphangiectasias and lymphoria, skin folds and skin jumps, and ulceration we can see. So entry points on the feet are fungal infection, it's maceration on the heel or between the toe, lymphangiectasias and lymphoria, that is also entry points, skin folds, which is very deep at patient with lymphedema, especially with patient with primary lymphedema, and then ulceration we can see at those patients, and beta hemolytic streptococcus infection can damage lymph vessels and leading to exacerbation of lymphedema. This is the patient I showed you before. So if we don't treat cellulitis or erysipelas, that's damaged lymphatic system, and then that increased recurrences of cellulitis and erysipelas is like circulus viciosus. So patient with cellulitis might have underlying primary lymphedema. What we know about that? Stoberl and his colleague said in 1987 that patients with cellulitis or erysipelas may have undiagnosed primary abnormality of lymph vessels. And Su and co-authors found that in 60% of patients with pre-existing lymphatic abnormalities have primary lymphedema. The same results found Dr. Damstra at his patients, and we can see that in our study, 80% of patients who have erysipelas on one leg, when we are doing lymphoscintigraphy, we found that the damage of lymph vessels is in the other leg too, so patients have primary lymphedema, not secondary, what we thought before that investigation. So risk factors for cellulitis and erysipelas are having lymphedema, no control lymphedema, having history of cellulitis of erysipelas, fissuring of toes or heels due athletic foot, tinea pedis and cracked heels, obesity, diabetes, and chronic venous insufficiency. Recurrent infection, recurrent erysipelas and cellulitis, we can find almost at 50% of the patient in last one episode. Recurrence have almost 55 of cases in 3 years, or almost 15% of patients with 1 year. So we have to treat this patient and look at lymphedema and treat cellulitis. How we treat cellulitis or erysipelas? We have to give patients oral amoxicillin or flucloxacillin. If the infection is very hard, we have to put the dose therapy intravenous. If severe the infection, other options are cephalosporin or clindamycin, and duration of the therapy must be longer, or at least 14 days. If patients have a lot of recurrence of cellulitis or erysipelas, then we have to give them oral penicillin 250 milligram per dose, or intramuscular benzathine penicillin every 4 weeks. But what about other therapy, not only antipyretics or analgetics, antiseptics or cold linings and antibiotics and adequate water fluid intake, but what about moving, and what about raise the leg during the episode of cellulitis, or what about compression therapy, and why we prescribe compression therapy at those patients as soon they get cellulitis or erysipelas. If we know during the infection increase the number of inflammatory cells and inflammatory mediators, so we can see color or warm, cause during the infection cause vasodilatation of blood vessels, so we can see rubor or red. During the infection, therapy increase swelling and patient have edema. And during the infection, expand the tissue under the skin that's irritating the nerve endings, and that cause the pain at those patients, and they have dolor or pain. So we can see classical sign of infection, which are color, rubor, edema, and dolor, and patient can move their leg or they have problem with moving. So compression therapy reduce all these signs of the infection, and patient will not have pain. And what about compression after symptomatic relief? We've done one study at patient with lymphedema, 45 patients with lymphedema after breast cancer, and 64 patients with lymphedema after gynecological cancer. They have erysipelas before therapy at first group 20 erysipelas, and in the gynecological cancer lymphedema group 18 erysipelas before therapy. We put those patients with lymphedema short stretch bandages, and then when edema is squeezing, they're wearing compression garments, class 2 on sleeves class 2 and class 3 on the leg. And after 2 years, we follow up every year. And after 2 years, we can see that in those range, they don't have any erysipelas after 2 years in the both group. So we can say that compression therapy minimizes frequency of erysipelas or relapses of erysipelas. So we can say at the end that early detection of treatment and treatment of lymphedema may reduce future episodes of cellulitis or erysipelas, that patients with cellulitis or erysipelas may have underlying primary lymphedema, and at the same time, the potential long-term consequences of cellulitis and erysipelas are lymphedema or leg ulcers. Thank you for your attention.
Thank you very much, Tanya, for this very interesting presentation. It appears that lymphedema and erysipelas probably the two components of a vicious circle, and it is nice that you presented to us that there might be some pre-existing underlying lymphatic problem in all those patients who experience lymphedema. We have 4 very distinguished colleagues who will have some questions to you. The first one is Dr. Latorre from Colombia. Dr. Latorre, do you have a video recording?
Yes, I am here. Okay, thank you. Dr. Rusinga, congratulations for your presentation. I would like to ask you if it's really difficult to make a difference between the erysipelas and cellulitis. As we know, if both have involvement of this lymphatic system, So why don't we speak of lymphangitis as a diagnosis first? Second, the therapeutic response to the treatment of lymphangitis depends on the guest response capacity and the virulence of the germ. Will be known is not only Staphylococcus, but also Pseudomonas enterococcus Klebsiella radically change the basic treatment. And third, we are very clear that there is primary lymphedema with episodes of recurrent lymphangitis that aggravate the process. But also, we know the existence of the secondary lymphedema to recurrent lymphangitis without previous primary lymphedema, which means they are two complete independent processes. So the hen is the hen and the egg is the egg. Thanks for your attention. Thanks to Sergio Gianissini for the invitation and the organization committee. Thank you.
Thank you for these comments. I agree with you. When we are talking about cellulitis or erysipelas, we don't see every time those lymphangitis. So I think that in different countries, we're using different words for, I can say, almost the same infection. And I agree with you. I just mentioned those most common bacteria which causing erysipelas or cellulitis. We know that if we have cellulitis on the face, there is the different bacteria, or if cellulitis or erysipelas have at child, this different bacteria who cause those cellulitis or those infection. So if we have opportunity or we have the wounds, then we take a swab and maybe we can make analyze colony of the bacteria which cause cellulitis or erysipelas, but it's not always possible.
Okay, thank you very much, Tanya. Let's go to the next person who is going to pose questions. Is Professor Vasily Petrov from Bulgaria.
Hello, everybody. Hello, Professor Giannoukas. Nice to meet you again after a long period of time of COVID infection. Nice to meet you. I want to thank you and Dr. Elena Goranova for my participation in this very interesting conversation. I would like to say that it's quite useful. You know, these patients with lymphedema are not quite interesting patients for our doctors, and very few of us deal with this. And so in this way, I would like to say that lymphedema is more and more frequent disorder, as you know. Obesity, sedentary life, predisposition are very common of this disease. Treatment of late stages is very, very difficult, sometimes impossible, as you see from this nice presentation of Dr. Tanya Rusigaya. The key for the treatment is early diagnosis, as she said, and treatment with compression, physical exercises, and medicaments is very important. The most severe cases, as we saw some in the presentation, need hospitalization and very often surgical interventions of different kinds, necrectomia, antibiotics, plastic surgery also, and so on. And as Professor Giannoukas says, this is a very vicious circle between the inflammation and lymphostasis, and one potentiates the other and vice versa. So progression impairs both these factors. And it is important, according to me, to tell the patients that there is no pill that they can take in and they cure themselves from this disease. This disease, according to me, needs a lot of physical exercises, lymph drainage, a lot of compression therapy, and at the end, some medicaments too. And then we shall have prophylaxis as important role for the treatment, because late stages are very, very difficult to cure. So this was my statement and comments on this. Thank you very much, Professor Gianoukas.
Thank you very much, Professor Petrov. Tanya, do you have any reaction to the comments or statement that Professor Petrov has presented?
I agree with all of that. Maybe I have to just say for the first questions that I agree that not all patients with erysipelas and lymphedema have primary lymphedema. We have to think about that, that there is a lot of patients who get erysipelas or cellulitis and don't have lymphedema. But we have to have in our mind that maybe that patient can have primary lymphedema.
Okay, Tanya, thank you very much. And we have to proceed with the next, who is a good friend of mine, Dr. Sokol Ksepa from Tirana, Albania. Sokol, are you here?
Yes, Professor.
Okay, please, go ahead.
Dear Professor Goranova, thank you very much for the invitation, and to all colleagues, nice to see you on the screen this time. I hope to see you again in another meeting in the next year, probably. Dear Tanya, congratulations for your understandable, clear, and simple way presentation. Being a vascular surgeon, I have, I think, two simple questions for your presentation and for this pathology, which as a surgeon, I don't see very often, but I can assure you that they are very problematic. So, in one of the causes of this lymphedema, you mentioned chronic venous insufficiency. Do you think that will be helpful to mention in the treatment that can you use micronized purified flavonoid fraction drugs, which means Daflon, for to reduce this edema and to help this patient? And the second question is for the treatment of the iatrogenic lymphadenectomy after breast cancer or melanoma, so malignant patients, which sometimes came with a very massive lymphedema. Do you think that will be one possibility, the surgical treatment of lymphovenous bypasses?
Dear Sokol, thank you for your questions. When we have patients with venous insufficiency, not all the patients will have lymphedema. We have to know that any edema we didn't treat can lead to lymphedema. And those patients with venous insufficiency and then lymphedema is really rare. But if we have patients with phlebedema and this and patient didn't treat it, then can become lymphedema or phlebolymphedema. And when we have patients with secondary lymphedema after oncologic reason, in the literature we can find the data that 30% of patients with any cancer or any treatment of this cancer can have secondary lymphedema. We know that patients have or don't have lymphedema, but we don't know why if they have lymphadenectomy. It's usually the question why patients with lymphadenectomy in the groin, all patients don't have lymphedema. we know that just some of patients have lymphedema, and the other question is why patient after lymphadenectomy in the axilla, why those patients have lymphedema, because we know that there is a lot of different way for lymph in the arm. So we suggest that patients after melanoma have minimal invasive procedures if it's possible, but we know that after lymphadenectomy and after punction of those only those lymph nodes where is the metastasis, all those patients can have lymphedema.
Thank you very much, Tanya.
Thank you very much, Tanya.
And maybe about
Please.
about the phloem or micronized flavonoids. There is some study who said that patients with lymphedema will be better if they eat those, those pills, and we have the study which talking about that there is no influence of the micronized flavonoids and lymphedema. So we have half and half the results after those study with micronized flavonoids.
Okay,
thank you very much, Tanya. Your answers are well received. And let's proceed to the last person who is in due to make questions. We have, it's difficult to pronounce the name. It's a nice lady, Nina Zavandantze. I feel sorry if I haven't pronounced properly this surname. Do you have Nina with us?
Hello, dear colleagues. My name is Nina Mjavanadze. It's a Georgian name. So thank you very much for introduction. And thank you so much for inviting me to join such respected specialists in phlebology and different fields of medicine. So I really enjoyed the conference and this presentation, and I don't really have questions left, but I just would like to make some comments that it's very important to provide the patients education, especially to those patients who are already diagnosed with lymphedema, so they can avoid getting erysipelas and progression of lymphedema after such severe infection. And it's also very important to provide the collaboration between us as vascular specialists, I'm a vascular surgeon, and also the specialists in infectious diseases. So we both know when to intervene with different types of treatment, whether antibiotics or special treatments for lymphedema. And we have all learned to treat patients with varicose veins. So now it is time to provide the best practices for the patients with lymphedema, which is more difficult and more challenging, but is very interesting. So we should really collaborate on that. So thank you very much.
Nina, thank you very much for your comments. Tanya, do you have any reaction to these comments?
Yes, thank you. Yes, I agree with that. So at our clinic, where is the only center for patients with lymphedema for whole country, so for whole Slovenia, patients with lymphedema when come to us every year, so once per year come to us if they don't need any other treatment, or if they need other treatment, then they often come to us. So I agree with you that we have to follow up those patients, that lymphedema at those patients will not progress. Thank you.
Thank you very much, Tanya. And it's time to pass the microphone to Dr. Elena Goranova for the presentation of the next speaker. Elena, the microphone is yours.
Thank you, Athanasios. Thank you, Tanya, for your excellent presentation. It is time to introduce Dr. Kristina Pavlova, who is expert physiotherapist from SOFIA Hospital Lublin. His presentation will be in video record.
Apparent techniques of multi-layer compression bandages application
as part of the complex decongestive therapy in cases of secondary lymphedema intensive care. Risk factors of secondary lymphedema of Operimp include mastectomy, extensive arm surgery, high number of removed lymph nodes, radiotherapy, chemotherapy, infection, inflammation of trauma, obesity, etc. The lymphedema control requires the following tools: complex decongestive therapy, physical exercises, intermittent pneumatic compression, risk factor reduction, patient training, skin care, prevention of the complications. The multidisciplinary approach involves rehabilitation team, oncologists, surgeons, and radiologist consultations. The objectives are swelling reduction, preventing its progress, lymphedema symptoms relief, preventing infections, affected lymph activity improvement, and patient's quality of life upgrade. We apply European Society of Medical Oncology guidelines, evidence-based physical activity guidelines for cancer survivors, treatment handbook of rehabilitation issues, guide of psychological support and rehabilitation in oncology. Complex decongestive therapy includes physical exercise, active and passive breathing gymnastics, lymphatic drainage massage, multi-layer bandages or single-layer elastic bandages, intermittent dose pressure therapy. It is recommended to start as early as possible after consultation and guided by a psychotherapist. There are two phases. The intensive phase is treated by manual lymphatic drainage, non-elastic compression multi-layer bandage, exercise, skin care. The maintenance phase is treated by low elastic compression bandage. The aim is to conserve the result. During the second phase, patient takes care of himself by periodically performing manual lymphatic drainage. Manual lymphatic drainage aims to move fluids from the swollen area to the unaffected area. The main schools for training are Folding in Austria, Fiodi in Germany, Leduc and Belgrado in Belgium, Castley Smith in Australia. They rely on similar methodologies: lymph node drainage, movement techniques, resorption technique. The concept of multi-layer bandages application relies on diverse materials layered to create safe and effective compression. Applied materials: cotton sleeve to protect the skin from injury, latex foam or cotton, short stretch bandages with predefined compression. The effect improves the interstitial fluid to the venous circulation, warms up the lymph, softens the fibrotic tissue, provides a pressure gradient to drain the lymph in the proper direction. Here you can see different types of multi-layer bandages. These are elastic sleeves. This is multi-layer bandages application on the upper limb. Intensive or maintenance phase treatment according to the lymphedema severity. There are 4 categories of elastic medical sleeves depending on the generated pressure. Compression class 2 medical elastic sleeves are most widely used in the treatment of lymphovenous edema. The main use of compression sleeves is in the long-term management of lymphedema, usually performed after a course of intensive treatment. Compression sleeves are also used to prevent lymphedema. Here are presented sleeves and gloves orthoses. Now you can see lower limb orthoses. These are our results after 10-day procedure according to Leduc and Belgrado method. These are Another 3 cases of the same method. Here are some multi-layer bandages, Mobiderm products. This is an illustration of their application and impact. Mobiderm product, and here is the impact. It is recommended to provide the patient with information on the risk of lymphedema occurrence and development, the self-care of the skin, prevention of infections, the necessity of self-massage, and the compression bandages and sleeves everyday use. To prevent lymphedema, weight control and weight gain are recommended. However, to draw a long shot picture on the whole treatment, I have to introduce a monocenter randomized double-blind trial with MPFF versus placebo. 148 women were involved with upper limb lymphedema after mastectomy. 24 of them suffered a severe lymphedema. The applied treatment was MPFF or placebo 2 tablets daily for 6 months. The evident results demonstrate that the lymphatic migration speed was significantly improved by MPFF in comparison to the placebo group. I am proud to introduce Victoria program. This program is created and implemented by a multidisciplinary team involving Pavlova, Koleva, Krsteva, Georgiev, and Adarska. The project is supported by the Bulgarian Ministry of Health. It refers to complex medical, psychological, and social rehabilitation of secondary lymphedema of higher limb after breast cancer. The intensive phase is provided in hospital and specialized rehabilitation centers. The maintenance phase is provided in specialized hospital for rehabilitation in selected natural and climatic zones. This program includes medical rehabilitation of syndrome Al-Shoulder, complex decongestive therapy of lymphedema, cardiopulmonary system rehabilitation. The emphasis was laid on breathing gymnastics, active and passive kinetic therapy, aerobic exercises, outdoor workout, climate therapy, hydrotherapy, swimming, art therapy, music, dancing, knitting, fancy work. Psychological rehabilitation engaged psychologists, social workers, and lawyers. The objectives are restoration of physical and mental health and patients' quality of life improvement. In conclusion, prolonged, complex, systematic repetition of therapeutic physical impacts leads to a positive effect and is a standard of behavior in secondary lymphedema associated with cancer surgery. The treatment and prevention of lymphedema and its complications result in a quality of life improvement. Thank you very much, Christina, for giving us this very interesting lecture and for clarifying the benefit of decongestive therapy, as well as the Victoria program on the cancer suffered women. We will have 4 questions from the discussion, but the first should be from Dr. Andonov from Hospital Ivan Rilski from Bulgaria, but he apologizes that he is in the operating room by urgencies. We have her comment.
Elena, thank you for the invitation to comment on this very interesting and well-presented presentation. Dear Christina, congratulations on the well-systematized presentation and on your efforts to treat secondary lymphedema. condition that is disabling to the patient and extremely persistent in treatment. I have one question. When complex decongestive therapy started, if the patient already has lymphedema, but chemotherapy and the radiotherapy are forthcoming, can be combined with them? And one more thing, don't you think that lymphedema after oncological operations is an underestimating problem by oncologists, and at the same time it's a big personal problem for the patients? Thank you very much.
Thank you for the question from Dr. Andonov, and Christina, it is your turn to answer. Christina, please.
Благодаря за коментара и въпросите. За съжаление, вторичният лимфедем при онкологични пациенти е пренебрегвана болест от онколозите, а той се явява медицински и психологически проблем за cancer survivors. Към всеки пациент в хода на рехабилитацията трябва да се подхожда индивидуално и конкретно с оглед избягване на метастатична болест. Работим в мултидисциплинарен екип и съобразяваме коморбидност и предхождащи заболявания. Няма противопоказания за провеждане на химиотерапия успоредно с рехабилитация. Единствен лимитиращ фактор е общото състояние на пациента, затова избираме 10 дни в периода между вливанията на химиотерапията. При радиотерапията рехабилитацията е за постигане пълен обем движение в раменна става. Тя е необходима за улесняване и поставяне на пациента в позиция на абдукция и външна ротация на рамото с оглед насочване на лъча в оптимална траектория, щадяща околни и подлежащи анатомично органи и структури, като бял дроб и сърце. Противопоказание за мануален лимфен дренаж може да бъде незараснала хирургична рана или кожна лезия или изгаряне следствие лъчелечение, тъй като и трите компонента на активното лечение, хирургия, радио и лъчетерапия, са фактор при генезата на лимфедем. След приключване на активното лечение на рака, виждаме по-добре цялата тежест на заболяването и предприемаме съответната рехабилитация. Доктор Горанова?
Thank you, Christina, for your answer. I would like to introduce Campisi from Catania University, Italy.
There is a recorded video here.
Hello to everybody. This is my question for the interesting presentation. This presentation tells us a lot regarding physical treatment and the gold standard based on the evidence-based medicine. My question regards the impact of surgery, so the timing of surgery. Because we know, thanks to surgical pathology, that chronic lymphadenus leads with time to a damage to the lymphatic structures, so lymph nodes, but also lymphatic vessels. In our case history, we do not wait more than 6 months if the lymphedema is reluctant to physical treatment, and we evaluate the surgical approach with the microsurgical reconstruction. So this is my question. Bye bye to everybody.
Thank you. Thank you, Campisi, for your question. Christina?
Professor Goranova, can I have to say a few words? First of all, you can translate to all participants what Christina said in Bulgarian, because I think she did not understand that she had to speak in English. And then I would like to comment on Dr. Campisi about the surgical treatment. As we very well know, surgical treatment is not very good option in lymphedema, because the results are not very good, especially long-term results. We know all these microsurgical operations, and even in Germany, in the Fiodi institution, they are not so eager in introducing these. So we must focus on physical therapy, we must focus on instrumental therapy, on different kinds of lymph drainage. That's according to me. And that I would like to hear some other surgeon, if there is someone, Professor Janukas, what do you think about this surgical option?
Dear Vasily, thank you very much. I think that the first line treatment is all these measures by physical means, exercise, massage, and everything. And I think this is just a minority of the patients who probably may need a lymphatic intervention, lymphatic bypass, etc. But still, these patients will recur without a proper after surgery, post-surgery management with these physical measures. This is my opinion.
Yeah, that's the right and correct attitude towards these patients. I fully agree with this.
Cristina, can you have an objection?
¿Puedo contestar en español, por favor?
We don't have a Spanish translation.
Окей. Не, нямам възражение, разбира се. Аз мисля, че тъй като генезата на заболяването е комплексно, всеки един метод има своето място. И за това говорим за мултидисциплинарен екип. И да, разбира се, и хирургията, и физикалната медицина имат своето място, така както хирургията и физичното повлияване и химичното при терапия на рака увреждат.
Thank you, Christina. Vasily Petrov, do you agree with? The next presenter is Corda from Italy, Domenico Corda.
My congratulations for your presentation. A very clear, concise, and above all, an evidence-based presentation. Firstly, I have a personal thought, and secondly, a question. My thought is that at the moment, a physiatrist at the end of his university studies does not have the skills to be able to coordinate a lympho team and to manage the patient with complex and complicated lymphedema. Really, the physiatrist should and will have to follow a theoretical and practical training course that must include a practical specific training in lymphological clinics. And now the question. We know that manual lymphatic drainage is a pillar of CDP, but as a standard technique, it is often not necessary to achieve a complete decongestion. Many patients respond well to CDP even without MLD. Do you consider whether MLD is necessary or not necessary for the patients? If so, how do you evaluate it? Both the results and the cost savings can depend on this evaluation. In a word, effectiveness and efficiency. Thank you. My congratulations for your presentation.
Thank you to Domenico for your comment, and it is an interesting point of view. Christina, do you have an answer?
Добре. Мога да? Благодаря ви за коментара и въпросите, доктор Корда. Да, трудно е обучението на физиотерапевтите и е много специфично. Затова работим в мултидисциплинарен екип. Комплексната терапия е индивидуална за всеки пациент. Тя е съобразена с преморбидност, коморбидност, обща физическа кондиция, стадии на лимфедема, наличие или отсъствие на инфекция и усложнения. Мануалният лимфен дренаж, физическите упражнения и компресивните превръзки или ортези са златен стандарт от 2015 година съгласно консенсус на ЕСМО. Работим на принципа на изключване на iatrogенна метастатична болест. Например, пациент в първи стадий на лимфедем може да бъде повлиян само с физически упражнения, дихателна гимнастика и дозирана интермитентна пресотерапия или апаратен лимфодренаж. Дихателната гимнастика осигурява градиент на налягането в големите колектори на лимфа в гръдната клетка, посредством движението на диафрагмата и гръдния кош. Втори пример. Пациенти в трети или четвърти стадии на лимфедем може да не бъдат повлияни изобщо от мануален лимфен дренаж, ако има предхождащ еризипел. Противопоказания за комплексна деконгестивна терапия и мануален лимфен дренаж са наличие на карциноматоза, това се казва точно така, инфекция, кожни лезии, трофични рани. Вашите снимки, доктор Корда, ясно го демонстрират. Благодаря.
Yes, thank you, Christina. It is time to present Dr. Yamaki.
Thank you.
From,
thank you for your introduction. Thank you for your excellent presentation. The treatment of patients with lymphedema is still controversial. Combined physical therapy with manual lymph drainage and compression therapy is most frequently used to reduce lymphatic arm swelling. However, objective evidence is still rare on the scientific basis. As Dr. Pavlov described, that complex decongestive therapy of lymphedema after cancer surgery can provide to move the interstitial fluid to the venous circulation. I would recommend to perform fluorescence microlymphography before and after intensive manual lymph drainage and compression. If the treatment is effective, spread of fluorescent contrast medium in the superficial lymph capillary network will be decreased. Again, thank you very much for giving me the opportunity to comment on the important topic.
Thank you, Dr. Yamaki. Christina?
Благодаря и аз, доктор Ямаки, за въпроса. Микрофлуоресцентната лимфография е перфектен метод за научно доказателство за ефектите върху движението на лимфата в увредените участъци. Защо чувам английския превод? Така ли трябва да бъде? Не. На база на доказателство с него, професор Белградо и сътрудници от Белгия създават методика за повлияване на адхезии с апарат за шокуейв и последваща пресотерапия с физиотерапевтична апаратура. Благодарение на този метод микрофлуоресцентна лимфография се прави картография и се демонстрира участъка на затруднено оттичане на лимфата и реканализация след третиране и терапия. В ежедневната практика обаче използваме методи от областта на физикалната медицина. Те, разбира се, са много по-икономични. Измерване обиколка на крайника сантиметрия, обем на крайника с използване на форма на пресечен конус, с които обективно отчитаме резултатите. Благодаря.
Thank you, Christina, and thank you for all discussion and speakers in this presentation. It is, thank you, Dr. Takashi Yamaki, and I would like to give the mic to Sergio Genesini to present the honorary chairs.
Indeed, I have the honor of introducing our honorary chairs, and as you can see from Italy, I allow myself to change the colors of our flags just a little bit because our flags are really similar. So you see white, green, and red in honor of Bulgaria over here. And since we are used to say that Argentinians are just Italian speaking Spanish, it's a double pleasure for me to introduce the comment of Professor Bottini.
Dear all, I'm very glad to participate with the Balkan Venous Forum during the Vein Week. First of all, let me stress that we need to make massive dissemination throughout the world about this hidden epidemic. Lymphedema, since as we know, some healthcare systems offer only partial coverage of this pathology, and we also know that this entity is easy to diagnose, difficult to treat, and impossible to cure, for which reason it requires permanent care. Also, there are many excellent schools all over the world that apply different therapies, and there has not been consensus on a common treatment, which makes it difficult to access to guideline and consistent recommendation. I would also like to ask about the efficacy of low compression in early stages of the disease. There is not a standardized staging in compression stockings based on different regions and companies. Finally, I would like to highlight the importance of the adjustable compression wraps, particularly during times of pandemic, given the autonomy they provide to patients. I wish to thank you all once again, and I expect to see you in Buenos Aires on September the 25 to 26 in hybrid event with all of Latin America. Thank you.
With this, we deeply thank once again Professor Bottini for having been at the starters of all these networking activities, and it is my huge honor and pleasure now to fly to the Genova University with Professor Campisi, who is with us in this moment. Professor Campisi, I don't know if you want to share your screen. If not, we are ready with our video. What would you like us to do? We go with the video, or do you want to go live? You're mute. Unmute yourself, please. I guess we go with the recorded video. So Khaled, if you are ready, I will try to share my screen. And then if not, you will go with yours.
Thank you very much, Sergio, for your kind invitation. I enjoyed very much the lecture of our colleague, Professor Goranova. Very interesting topic. And that's why I would like to underline some aspect of the problem on the guide of our long clinical experience and research. You can see here the three levers of lymphatic pathways from the subdermal layer, level 1, to the subcutaneous epiphyseal level, level 2, and the subfascial deep level 3. For the staging of lymphedema, I would like above all to underline the studies we have conducted on the immunohistochemistry of lymphedema. And the different degrees of the impairments, lymph nodal, lymph vessels, and interstitial matrix impairments, we can see in the progression of the lymphostatic disease. And on the basis of the pre-op and post-op evaluation, we can underline the possibility to identify superficial and deep lymph collectors able for the lymphatic venous anastomosis. We can select the best lymph collectors on the level 1 and level 2, and also together with collectors of level 3. You can see in this slide the possibility, for example, at the inguinal crural region, to identify in the same time superficial and deep lymph collectors. And lymphoscintigraphy can show the patency of this multiple lymphatic venous anastomosis, not only for the upper limb lymphedema treatment, but also for the lower limb lymphedema treatment. Lymphoscintigraphy is very important according to the Genoa protocol, and we defined the procedural recommendations in the diagnosis of peripheral lymphedema and the rationale for the study of the deep subfascial lymphatic vessels during lymphoscintigraphy for the diagnosis of peripheral lymphedema. And on this basis, on the guide of this study, we can do the screening of cases for multiple lymphatic venous anastomosis only with superficial vessels, and above all for the multiple lymphatic venous anastomosis with superficial and moreover deep lymph collectors. And another aspect very important to underline, to highlight, is the rationale behind the single site approach, that is twofold: lower the infection risks and increased vessel caliber. You can see here some clinical cases for upper limb and lower limbs by this kind of technical procedure for primary and secondary lymphedema, with the long-term clinical outcome and very satisfactory results. And by microlymphography, by indocyanine green fluorescent microlymphography, we can verify during the surgery the patency of the anastomosis. But for phlebo lymphedema with venous superficial and deep hypertension, varices and post-phlebothrombotic sequelae, we point out at the early 80 years. This technique of autologous interposition and vein graft, or MLVLA, multiple lymphatic vein lymphatic anastomosis, with the honor to have had the reference and the recognition also by Mayo Foundation for Medical Education and Research. It is very important to see and to identify lymphatics during venous surgery. As you can see here, along the internal saphenous vein, and we can perform also surgical ablation of the saphenous vein, recognizing the lymph vessels, and with prevention of possible lesions to the lymph vessels during this surgical ablation. You can see here some examples of this procedure we apply. In our clinical registry, we have a large series of cases treated by these microsurgical procedures for lower and upper limb lymphedema, primary and secondary. And the protocol we apply with phase 1, phase 2, and phase 3 of a complete lymphedema functional treatment staging guide, with only 1 week devoted for surgery. That's why between phase 1 and phase 3, also conservative procedures, conservative treatment can be applied with very satisfactory results in the long term. In our algorithm for lymphedema, we can identify not only the stages and the steps of the treatment, but also in the same time the prevention of the progression of lymphedema. And then we can define primary prevention without lymphedema clinical manifestation, and the secondary prevention for lymphedema early stage, and the tertiary prevention we can realize by complementary techniques of selective liposuction, like our fibro-lipo-lymph aspiration with lymph vessel sparing procedure. Thesis, like in this only with this selected indication. Then our activity is devoted to the research, to the training, and to the application of lymphatic microsurgery, and the international cooperation, like the WIN cooperation with the International Phlebology and lymphology is very important to ensure the progress and the advances of this very important aspect of the clinical pathology. Then, at the end, I would like to thank you, together with all our co-workers of our team, and remember the Lymphedema Day in the 6th March every year. We celebrate this important day all over the world. And another important appointment is the International Society of Lymphology Congress. We will organize in Genoa and Turin in 2023, and I would like to invite you to participate with best regards for you and for very prestigious work.
With this, we thank you, Professor Campisi. Professor Petrov was making a comment before about lymphatic surgery. I don't know if he's still available and if he wants to comment on this lecture. And if not, is there Professor Petrov?
I'm here.
Yes.
I would like to comment.
Yes.
This is a very interesting presentation. And I think that a very good surgeon spoke to us. But still, I think that the long-term results, as far as I know, and as far as we have performed here, are not quite satisfactory, because sometimes you don't have even primary patency, which is good enough so to perform this kind of operation. But probably in the future, this is a trend that should be supported, because microsurgery is not so well developed all over the world, I think. And these enthusiasts, these people who are enthusiastic in this field should be supported. So,
thank you so much, Professor.
Yeah.
Thank you.
Petrov. Professor Campisi, one final remark on Professor Petrov's comment?
Thank you.
Okay.
Many thanks.
Thanks to you.
For me, it's very important to have this kind of opportunity to present our 50 years evidence-based experience of the Genoa School. And then every occasion we have to present our work is very important for us and for, above all, for patients. That's why I would like to invite all of you to approach the problem of lymphedema in the early stages, and to avoid the progression of lymphedema to the extreme elephantiasis like up to date we can see in patients not properly treated. And
thank you so much.
It is very important to do this kind of long approach.
Thank you again.
Chronic disease, a chronic approach.
Thank you so much, Professor Campisi. Now we move forward toward the end. Just the final remarks from Professor Chi from the University of California, Davis, wrapping up this excellent webinar.
Thank you, everyone. It is my honor and privilege to participate in the SOFIA project as part of the Vein Week program. I will be discussing the take-home message for today's lessons. I am Willie Chi from the University of California, Davis Vascular Center. Through Dr. or Professor Ruchigal's talk, we now have a much better understanding of the chicken and egg story between lymphedema, cellulitis, and erysipelas. Dr. Ruchigal gave us a clear definition of cellulitis versus erysipelas, the interconnection between lymphedema, cellulitis, and erysipelas, as well as the risk factors of infection and recurrent infection in lymphedema patients as outlined. Now, the underlying story is the chicken and egg story. Is lymphedema the cause or the result of infection? It is yet to be determined. We also was taught about the treatment methods, including the various form of antibiotic therapy and timing, as well as compression therapy. For Dr. Pavlova's talk, it's an elegant talk on the different methods of bandaging in lymphedema patients. We know that lymphedema control requires multiple different tools, as well as multi-discipline approach to the care of patients. We see the different forms of applied materials and individual effects. Dr. Pavlova also gave us examples of bandaging techniques, a slide on the veno-active medication, MPFF, and last but not least, the Victoria Project. Last but not least, Professor Giannassini gave us an evidence-based talk on the veno-lymphatic hydrotherapy, that the evidence really started in the 1990s through the work of Professor Ernst Carpentier and lately Professor Giannassini, that led to the conclusion of the data project or the data study, as well as the study on bioimpedance. Now, with these evidence that are available to us, that exercising water may be a way to go to exercise our veno-lymphatic patient. And with that, I want to thank you all for your attention.
With this, we deeply thank Professor Chi. I think we have a patient's contribution now, Khaled, ready to go. And then we will have the big conclusion with Professor Lee. Elena, if you want to introduce the patient organization.
Yes, I will be. Here we can see the some spots of the truth of our patient. She's with lymphedema 20 years ago, and it is Tsvetlana Miloslavova who spoke to us.
You cannot see the video?
No.
Лимфедема за мен е като един съжител. Точно така съм го приела, след като разбрах, че е нелечим. Приела съм го като един съжител, с когото аз трябва да живея и за да мога да се разбираме, аз трябва да го ухажвам и да му угаждам. 2 години го оставих.
The video is coming in Bulgarian. So we need that in English.
Да. Така че това се опитвам да кажа на
пациентите. So the technical part is to move to Bulgarian.
Най-важното е да са последователни и да са търпеливи и да разберат, че целият ми живот зависи от да не са в тежест както на близките си и да са полезни за себе си, защото това е основно, това мен ме движи. Да съм полезна за себе си и да не съм в тежест на близките си. Те трябва да направят всичко, за да могат да всички тия процедури и това е всекидневна грижа към този родител.
Какво според вас трябва да правят? избройте го, нали, масажи, носене на чорапи, хигиена, всичко.
Това, да, значи първото трябва да си, обикновено се обаждат, ама ми се поду, трябва да отиде да се установи диагнозата, след това трябва да се види откъде идва това нещо, нали, това заболяване, в смисъл откъде е този отток, ако те нямат вече представа откъде. А след това вече задължително трябва да само се облекло, задължително. Значи аз масажи няма кой да ми направи. И съм открила за себе си, въпреки че някои отричат лимфопресата. Значи може да не е препоръчително, нали, много, но за мен това е решение, защото в моя край няма и аз не мога да пътувам, за да си правя тези масажи. Да. Нали, всеки път на мен ми излиза супер скъпо. Те самите масажи са скъпи и за да отида някъде, аз трябва да си подсигуря и престоя за тия 10-15 дни и да плата масажите и аз предпочитам да си купя за тези пари една лимфопреса.
Ще приложим техника на комплексна деконгестивна терапия. Ще направим мануален лимфен дренаж. Първа техника от мануалния лимфен дренаж е изпразване на лимфните възли. Изпразване на аксиларните лимфни възли. Техника на придвижване. Може да обработваш едновременно успоредните зони. Техника на резорпция. Поставяне на памучният ръкав. Поставяне на дяна. Трети слой – ниско еластичен бинт. Последен слой – еластичен бинт с дозирана компресия.
And with this, we move toward the end. So please allow my screen sharing for the big introduction of our key opinion leader, Professor Vasily from George Washington University. No needs of introduction for the one we consider also the ambassador for the vein weak in the lymphatic system. I know we have a recorded video. I don't know if Professor Lee prefer to speak live or recorded. Professor Lee, are we going live or recorded? So I think you can play the video, Khaled.
Thanks. It's recorded.
Yes.
Good morning, ladies and gentlemen.
We are not seeing the video, so please play the video. Thank
you. I would like to congratulate Professor Goranova and the Balkan Venous Forum first for this excellent meeting to share changing concept on venous and lymphatic circulation through this vein week with the Venous Lymphatic World International Network movement. And I also would like to thank the Sergio and organizing committee for this unique opportunity to participate to the campaign for proper recognition of overlooked interrelationship between two mutually interdependent venous lymphatic dual outflow systems. Indeed, a failure of one system, either venous or lymphatic, gives additional burdening to the other system. Hence, a long-term failure of one system results in total failure of both systems altogether, generating a new combined condition of chronic venous insufficiency and chronic lymphatic insufficiency, so-called phlebolymphedema. Hence, venous and lymphatic system has been belatedly recognized as one inseparable system with ever increasing appreciation, and I'm so happy to see the colleagues sharing same view through this conference on this negligence to be compensated as a whole. After all, the venous system and lymphatic system are one happy family we will have to appreciate together. So I would like to extend my appreciation and also congratulations to each speaker who generously shared their pearls through this unique virtual conference, and further to Dr. Ruskac of Slovenia in particular. Dr. Ruskac has brought up such critical view on the cellulitis and erysipelas as an early warning signal on possible involvement of primary lymphedema as a hidden underlying cause. With her timely conclusion, with early detection and treatment of lymphedema may reduce future episodes of cellulitis and erysipelas and their recurrence, which I cannot agree more. At the same time, the potential long-term consequences of cellulitis and erysipelas are indeed lymphedema and leg ulcers. Thank you.
With this, we deeply thank Professor Lee for always being our giant. Since he's here, Professor Lee, would you like to have a final remark? If you want to unmute yourself and have a final remark. Professor Lee, we cannot hear you.
Yeah, thank you,
Yes.
Sergio. Well, we spent quite a long time extra, so I think it should be more enough. I thank everyone who participated, spending these long hours. Thank you.
Thank you so much. We conclude with a brief significant surprise about SOFIA, because indeed in this vein week there were initiatives including also the sport world. So there is an initiative called SMASH Venous Thrombosis Risk that has been possible thanks to Dr. Pittman from US, who introduced to us a volleyball champ from US, who very nicely interacted with the Balkan Venous Forum thanks to Professor Dimitrov, and also the SOFIA national players of beach volley, for which these players will be opponents in SOFIA for a competition, but they will be together as teammates in the promotion of public venous lymphatic awareness. So here is their message. And we go for a surprise to Professor Goranova and all the colleagues and friends from Balkan Venous Forum. This is an atypical surprise because we are gathering together with huge sport athletes from the beach volley world, Tracy Callahan, Vili and Roya from Bulgaria. We are here thanks to Dr. Pittman from Miami, who introduced me to Tracy Callahan, a huge champ on the beach volley field, but also in terms of public venous awareness. She's ambassador for our Vein Week Global Project. So I found wonderful the fact that Tracy reached out to her colleagues from Bulgaria, because Bulgaria is a wonderful country hosting huge sport events, in this case beach volley, and also huge scientific events like the one of Balkan Venous Forum. So I'd like just to give the mic to the athletes for a second, because they will be competing on the beach volley field in Sofia, but they are today in the Sofia meeting, promoting together as teammates public venous awareness. Tracy?
Thank you, Sergio. Yeah, so for me, it's a wonderful opportunity not only to be able to compete in Sofia at the end of May, which for me will be the first international event that I'll be able to compete in since, you know, post-pandemic. So it's great to be able to have Vili and her sister Raya here, you know, to advocate for Sofia and the city that they live in, where they train at. So thank you, ladies, for being here, and I'll go ahead and pass the mic to you.
Thank you, Tracy. We're honored to be here too with you guys having this conversation. We feel really blessed that SOFIA is hosting sports events, but not only sports events, but also great scientific events. We think this is like a very nice way to improve. Yeah, we're glad having you.
Thank you so much. And now Dr. Dimitar Dimitrov, who is indeed one of the hosts of this wonderful Bulgarian initiative. Dimitar?
Thank you. I'm a general and vascular surgeon in Sofia, and I also practice sports, and I recommend to all my patients to be physically active to the best of their ability, so they will be not only in good shape, but also in good health.
And with this, we look forward for being in Sofia, for enjoying another wonderful Sofia scientific meeting, but also a wonderful Sofia competition among competitors during the match, but the teammates in everyday match against the venous and infectious disease. Thank you so much, and have a nice rest of the day.
Thank you.
Thank you. And with this, we deeply thank the athletes, and we pass the mic to the hosts.
Thank you, Sergio. Thank you for this wonderful surprise. I like very much this video, and it is a little bit fresh air.
It is. You're muted. Unmute yourself.
Unmuting.
Yes, now we can hear you.
I repeat. So thank you, Sergio. Thank you very much for your wonderful surprise. It is very nice fresh air in our webinar, Lymphedema webinar. And going to the final, please share the, yes, the next, please, Khaled.
SOFIA project became possible with the support of our sponsors, Laboratoire Servier. For more than 27 years in Bulgaria, Servier is dedicated to the public awareness, detection, and early treatment of the chronic venous diseases. Health 2000 Limited, the local distributor of USO products, the perfect support to make movement more enjoyable. Valentis, the Swiss quality, from natural ingredients to nanotechnologies. Valentis seeks to take the lead in all areas of natural medical treatment. Teva, a global leader in the pharmaceutical industries, developing, producing, and marketing affordable, high-quality generic. Inothera, Inotech Bulgaria, treat daily pathologies.
We are on the final words of our presentation. Sergio, do you want to say something in the final?
I will just say once again, thank you as Italian for having felt that this green and white and red is really mixed in the way we want, because it looks like the Bulgarian or the Italian flag. So it has been really feeling at home, co-working together. I truly hope this difficult time of the pandemic has been once again the opportunity to co-work more and more among different nations, and also even more among the venous and lymphatic world. For this, I deeply thank the Balkan Venous Forum for having organized this first, I hope, of many other webinars together.
Thank you. Athanasios, do you want to say something?
Yes, thank you very much, Elena. I'm very glad that this webinar went smoothly, and I think we presented what is the state of the art of lymphedema progression these days. Thank you very much, Elena, for including me to co-chair this webinar. I would like to thank all the presenters because they presented a really good stuff. Also, I would like to thank all the distinguished speakers and commentators and participants because they created a really important event. Thank you very much from my side and hope to see you physically next time without having this risk of the pandemic. In the meantime, please remain safe and healthy.
Thank you, Athanasius. Thank you very much. Well, we are already on our run of the finish. Today, we watched interesting standpoints of the benefits of hydrotherapy, the risk of erysipelas, the advantages of Victoria program. Hopefully, all of us leave this meeting being enriched and with innovative ideas. Thank you to all experts for your contribution, which brought the discussion to a high level. Thanks to Alex for interpreting Bulgarian to English, as well as to the translator in Spanish. Thanks to Khaled Zidan and his team for the excellent technical support. Deeply thanks to Professor Sergio and Genizini and all partners in the VWIN Foundation for inviting the Bulgarian Venous Forum, the Balkan Venous Forum, to our platform. I wish a successful Ven week. Goodbye.
Thank you. Thank you all. Bye.
Bye-bye. Bye-bye.
Thank you.
Bye-bye to everybody.
Bye-bye.